So welcome everybody to this event, welcome everyone in the room, and also to a really great number of people who have joined online as well. This is an event hosted by the LSE's International Development Department and also our Global Health Initiative, which brings together scholars working on global health from across the school in a whole range of different departments. I'll be your chair today. I'm Philippa Mladowski. I'm an associate professor in the International Development Department. My work is on universal health coverage and health financing. For many years, I worked on community-based health insurance, so I'm really interested in communities, community development, and community health workers, so I'm really delighted to be chairing today. So I also wanted to alert you to the fact that the event is being recorded and will be available on our department's YouTube channel as well. So we're very excited to welcome our guests today. The freshly award-winning Community Health Impact Coalition, or I think is the right pronunciation, yes? CHIC, okay, I like that.
Exactly.
Who are here in London as recipients of the Rue Prize. So yesterday evening they were at a wonderful gala where they received their prize from the Institute of Health Metrics and Evaluation, the IHME, which the prize was awarded to Dr. Madeleine Ballard, who will be talking to us later, who is the CEO and co-founder of CHIC. And so she won the award on behalf of the organisation for her work alongside thousands of community health workers to secure quality of care for all through evidence-based health systems benefiting millions of people across the world. CHIC has played a key role in influencing guidelines, increasing funding, and advancing the development of national policies needed to make professional community health workers the norm everywhere. Before becoming CEO of CHIC, Madeleine earned her PhD from the University of Oxford as a Rhodes Scholar. She is also the recipient of the Harvard Women's Leadership Award and co-founder of the Anti-Racism Task Force at the Arnold Institute for Global Health. Our other speakers here on the panel are here, and one person online who I will now introduce. So we have Dickson Mbewe, we have Prossie Muyingo online, and James O'Donovan, who are our panelists. So Dickson, hello, welcome Dickson, was motivated to become a community health worker by immunisation teams who came to his village. Dickson is active in advocating for support for community health workers who are on the front lines, including in the formation of the National Association of Community Health Workers in Malawi. Prossie, who is joining us online, has dedicated her life to serving as a community health worker in central Uganda. She's at the forefront of providing essential reproductive, maternal and child health services to 186 households. With the onset of COVID-19, Prossie emerged as a pivotal figure in her community, offering dependable information about the virus and safeguarding the health and well-being of those around her. Prossie passionately champions the professionalisation of community health workers, and in her role as a CHIC community health worker organiser, she advocates for the implementation of legislation by governments, policymakers and funders, and is a founding member of the National Association of Community Health Workers in Uganda. And she was recognised as a Heroine of Health in 2023. Unfortunately, due to visa difficulties, Prossie is unable to attend this event in person. This is an illustration of how immigration regimes contribute to inequity and injustice in the movement of health workers and distribution of health workers globally. And it's all the more pertinent given that this is one of the topics that we will be maybe discussing today, depending on what comes up in the Q&A. But we're very fortunate that she's able to join us online, so thank you, Prossie. But we've kept an empty chair for her here as a visual reminder of this injustice. James is Director of Research at the Community Health Impact Coalition. He leads a team of global health experts, making professional community health workers the norm worldwide. He also serves as a technical advisory group member at the WHO, contributing to the development of a prototype community health worker curricular guide, and also remains clinically active in the NHS as a medical doctor. I also welcome our moderator, my colleague in the Department of International Development, Dr. Tine Hanrieder. Our event today will be quite informal and will take the format of a fireside chat, and Tina will be helping us by asking questions to the panelists, and we'll also get the ball rolling before we open up to the Q&A. Tina is very well placed to do this, given her current research on the emergence of the community health worker role in the US and on the governance of international nurse recruitment in Germany. She's an associate professor in the Department of International Development and is the author of a monograph on the history of the WHO and of articles spanning the areas of global health governance, global medical education, international relations theory, health security, and humanitarianism. Okay, so that is the introduction so that you understand who everybody is and what we're doing here today. Before we start the panel, we actually have fresh, hot off the press. I think nobody other than the guests at the prize-winning the event last night have seen this video. We have a video that was made about Chic by the Rue Prize organisers to help them to promote their fantastic work. So you're very lucky that you are able to see this today, so it's just been emailed through. So we're going to take just 7 minutes to have a look at this film, and then we'll open up to the panel. Okay.
Before community health workers were there, we had a challenge. As a community, we could move a long distance to get the services. And at times when you go to the health facility, there is no medicine. So you end up going to the clinic, and not everyone in the community can afford money to go to the clinic. So when this program came of community health workers, in fact, it helped a lot. As community health workers, we were trained. After being trained, we were supplied. And now we can do the services. We are treating children under 5. We are visiting the pregnant mothers. We are doing nutrition assessment, which was not there at first.
Around the world, millions of community health workers are working without recognition, without pay. 70% of those community health workers are women. You have people who are being exploited. And on one hand, they either leave or they are working without pay, hours and hours and hours and hours a week. If they do leave, then the patients are going without care. And as a consequence, we're in a world now where 1 billion people go their entire lives without ever seeing a health worker. Community Health Impact Coalition is a team of community health workers in 60 countries around the world who've come together to make professional community health workers the norm by changing guidelines, funding, and policy.
Nama Wellness was established in 2014 as a health center, a community-based health center, basically offering primary health care services. And so that attracted a big number of women from the community. But the biggest part of it was when we joined Chic and designed a community health workers program based on the Chic 8 principles.
We are the doctors in the community. We are very crucial in the work of the community. I do follow-ups where necessary. I treat and refer children under 5 years for malaria, pneumonia, and diarrhea. I do family planning also, but we know through training we can be professional CHWs. So as CHIC, it's an umbrella of CHWs globally to make a professional community health workers a reality.
This advocacy course is made up of 6 modules. You get to know how to use the digital tools and join others globally.
community health worker will learn, A, you're not alone. You're not just off in a far-off village by yourself. You're actually part of a whole community of community health workers from around the world, stretching back over time and into the future.
So we need to come together and fight for a good working environment as CHWs.
There's a really serious health worker shortage that's actually getting worse. And the WHO says we're going to be short as a globe like 17 million health workers by 2030. So folks need care, we need people, and I think community health workers have really been able to step into that gap. And the biggest provider of healthcare in most places is the government.
We have also made it clear to government partners and implementing partners that as a country, if we are to change the status quo from curative to promotive and preventive, as a country, we have taken a decision that community health workers is the way to go.
We've seen that community health workers can actually increase access to basic healthcare services. They can increase and promote equity in the community.
We're living in a digital world, right? And the temptation is always to say, oh, let's fix that with an app or a drone or something. And these tools are amazing, right? And they can really support us in reaching more people more easily. At the same time, I think people know pretty intuitively that you trust your neighbor more than you trust the internet. So we need to advocate to get more money better spent on professional CHWs, but in order to make that kind of global reality a reality for every community health worker in every country, that's where these networks come in.
We don't want community health workers to be exploited because they cannot stand up for themselves.
Let's get community health workers in the room and let's establish that unified voice.
And they're not just speaking for themselves. They're speaking for 700. They're speaking for 7,000. They're speaking for 70,000. Now we're really getting somewhere. I look forward to standing alongside you as we change the health system in Uganda.
Our voices have been missing, but now the more we advocate, the more we'll be getting that change we are crying for.
Once they speak, they're always the most powerful speaker in the room because they have that authority, they have that legitimacy, that credibility, and they have the insight that nobody else has because they're on the front lines every single day.
When we bring together CHWs and we all have the same voice and use the same voice to advocate at national level, then we believe that these changes will be seen.
I'm really proud of obviously what we've achieved together as a team. I think so much of both the research and then the advocacy has changed how people think about community health workers. Like if you hear 86% of community health workers are unsalaried, that's chic research. Salaried, supervised, skilled, supplied, produces better outcomes, that's chic.
Print your prescription.
Our goal is to see 95 countries recognize and pay CHWs. And what we're seeing is a rapid acceleration just over the last 5 years in terms of the number of countries who are making this switch. We're, just over a third of the way there. It's 60 countries to go, and I think we're on track to hit that tipping point really soon. To win that commitment is so important because it's someone finally saying, "You're right. You're worth a lot."
It's time for CHWs to take our seat, to sit with the decision makers and the policy makers, because each and everything starts in the community where we are and end the community where we serve.
Yeah. What do I need to do? On. Green on. Yeah. Oh, it is. So delighted you're here. Very excited to moderate this panel. Philippa has already said my work has been with community health workers in the United States, which it's not as different as you might think. But also I've been connected with the coalition for some time and following the work of Chic for some years. And I'm not at all surprised that you now also got that award, in addition to a lot of attention in the media and luckily by policymakers. So good that you're here, and there's so much to be learned from you and your advocacy and from doing this work. I just wanted to say, because we have a lot of health and international development students in this room, and this event is sponsored by International Development and the Global Health Initiative, that I find that normally we are getting better at seeing all the historical reasons why community health workers continue to be exploited. And we are sort of getting better at understanding the injustices and the inequalities that perpetuate that critical work at the front lines is not rewarded as it should be, or that the projects that are celebrated are at the same time not properly resourced, and that so many lessons are not learned, and that the insights and the voices of community health workers and their skillful work are not as prominent in policy debates as they should be. And it's now 50 years or so since the emergence of the primary healthcare agenda, and a lot of celebration and attention to community health worker programs. But still, I mean, I think we hear less openly dismissive remarks about labor rights claims by community health workers than we did. But there is still sometimes a conspiracy of silence around the demands of community health workers. Madeleine is also quite good at calling out organizations still drawing on volunteerism without properly thinking through what community health workers should do. So really so glad that you're here and that you're sharing your experience with us, and that you are not so much looking at the past, but that your eyes are set on the future and that you're pushing for change. And I think we will start, and I would just ask Dickson to please introduce a bit, what's it like? What's your work as a community health worker? What do you do and how is it?
Okay, thank you so much. My name is Dickson Mbewe, community health worker in Malawi. So to start with, as a community health worker, I'm headed by a work plan. So before I do anything at the end of the month, I have to set up a work plan on how I'm going to do my work, either through the week or the whole month. So there are a lot of activities that I do in this community. For example, we do vaccinations. If you can remember, we had a very end of COVID-19 in 2020, like that. So as community health workers, we are on the front doing vaccinations, and this helped to reduce the infections. So apart from that, we also do defaulter tracing. Those patients who defaulted on TB drugs, we have to follow their communities and take back to the treatment areas. And also we do make follow-ups to pregnant women and also neonatals. In case there are danger signs, we have to identify them as early as possible so that they are treated at the facilities. We also do community assessment, we do village inspection, we do disease surveillance. Also, we do reporting on various issues in the community. So our work is just so huge. So over 95% of our work is done in the community. We are the cornerstone of health system across the world. We are part of the communities, and also the communities part of us. So each and every time we are connected with our communities, we are able to treat, especially under 5 children, we are also able to refer all those issues that need to be seen at the facility. So in brief, that's what we do as a community health worker. Thank you.
Thank you, Dickson. It sounds like a big week and a long list of things to do. I feel like I should follow up with you, but also want to meet online Prossie about a similar question, which is, are you here? I wish I had met you in person. What do you think are the most rewarding parts of your work as a community health worker, and on the other hand, the most challenging parts?
Thank you so much, and I'm happy to be and sorry to miss physically. So, as Prossie, you have already talked about the work we do in the community. Thank you, Dickson. I'm proud the moment in my career as a pro CHW that stands is that I realize that in our work we can be professionals and continue serving our communities. So then and be recognized as professionals. Often we work in difficult conditions, but seeing our efforts encouraged globally has been incredible, empowering. Another proud moment I had was when I was shared the platform with the professionals, with the doctors, with the policymakers and the funders. So that day I was really too happy. Another is the day when I was nominated by Women in Global Health to be the Heroine of Health in 2023. I was too happy. And still, I'm proud to be part of the team advocating for professional CHWs globally. A team which is recruiting our fellows to do the course, and so that our voices be heard. A professional community health workers whereby we will be salaried, skilled, supplied, and digitally strengthened. Despite those achievements, I face significant challenges, such as digital exclusion, information overload, communication barriers, limited time and resources. So I can overcome those hurdles. As you all in the audiences and those who are attending this conversation, if you do something and you support me, Prossie, and we continue recruiting our fellows and do the course, or you closer collaborate to ensure I'm supported to continue mobilizing my fellows and form a national association where we will be counted as professionals and be counted as frontline health workers and compensate, and our work will be compensated. Thank you so much.
Amazing, thank you both. This event and the award brought many of you together. I gather that the team is working across many sites normally and is also having a research component. So both of you are organizing nationally and also transnationally in the coalition. And then we have James here, who is the research director and holding the research efforts together, I guess. How would you describe the collaboration that's going on in SHE?
Yeah, so the research effort is a really huge effort and it brings together so many people. So SHE is made up of, as Madeleine articulated in the video, member organizations across multiple different countries. And we have 3 different tactics that all feed into each other. So we have a research group, we have an advocacy group, and we have what we call an activate group, activating in-country networks of community health workers, such as Dickson Mbewe, Prossie Muyingo. So the research group has 70 members as part of that group, and we're spread across multiple different countries, across sub-Saharan Africa, Guatemala, Nepal. And so it's a really huge collaborative team effort. We try to do things in a relatively innovative way, one of those being involving community health workers at every step of the research process, because we know that community health workers, especially in the research field, do the vast majority of the grunt work and the legwork in terms of going out into the community, consenting individuals, gathering data most importantly. And Dickson can probably articulate this a little bit later on, but we recently have published a study that's been accepted in Lancet Global Health, looking at the role of community health workers in research studies. So we looked at all of the research projects that have been done involving community health workers over the last 10 years. And there were 2,000 of those studies, so a huge volume of literature. And what we were interested in finding out was, how have community health workers been involved in these projects? So we dived into all of the literature, read every single study, and split it up into three main areas. How are they involved in the implementation? How are they involved in the design? And how are they involved in the dissemination? And kind of unsurprisingly, we found that in over 50% of the studies, CHWs were really heavily involved in implementation. So they were going out doing all the legwork on these studies. But then we kind of went one step beyond this, and we looked at how are community health workers actually been acknowledged. So they're doing 50% of the work in terms of all of the heavy data lifting. You'd assume that they were going to be represented as authors in 50% of those studies. But actually what we found was they were only represented as authors in less than 15% of the studies. So there was a big kind of power imbalance there. So, careers are being made on the back of community health workers. Huge grants are being gained on the back of work that Dickson's doing, that Prossie's doing. And so something that we try to do at CHIC is really involve the community health workers at every step in the process, both in terms of having a seat at the table here when we're speaking to people, having a seat at the table when we're speaking to policymakers, but also in the space of research, having a seat at the table when we're doing the research, but then also publishing it. And hopefully Dickson will be able to speak more to his experiences of being involved in this. Yeah.
Dickson, would you like to share with us what it's like to add research to your talk?
Yeah. Yes, great. As it has already been said by James, at first it was so difficult for a community health worker to be involved in research. So it was like a huge mountain to climb. But when CHIC came in with the research component, so it was so interesting. You see, after publishing and reviewing some of the articles, you are able to see that maybe we were lacking somewhere to do a good job to our communities. So we find that the research articles has helped us, a lot of CHWs, to understand what is needed by the communities and also what is not needed by the communities. Sometimes people sit in the office and publish some articles so that some people that implement them in the communities, but they don't work because they are not basically needed by the communities. So, but when we are involved as CHWs, we're able to understand, and we're also able to know that this will work and this will not work. So this has already helped us much to do the good work in the communities, and also the communities have benefited much from the research articles that we have published and reviewed. Thank you.
Also, what does not work? Thank you so much. I see a lot of people, yes, in the audience.
I think that is a really important point, though. Yeah. It's just as important, especially for students in the room, to not always expect like positive results. Sometimes good to find out what doesn't work and why it doesn't work. And working collaboratively and synergistically with the community health workers is really beneficial for that. And also, just to frame this, when you ask Dickson, what does he do? It probably would have been easy to ask Dickson what he doesn't do, because the list was so long. And we're not trying to make every single community health worker a researcher. We know that not every community health worker wants to do that, but at least that opportunity should be afforded to them as professionals. And I've learned so much from Dickson, both in terms of what project should we be pursuing as a group. And also Dickson keeps me right in terms of, recently we had a paper, there were 400 data points, and I sent it to Dickson and I said, what do you think of the paper? And he kind of meticulously went through all of the results. I said, all looks great, but I'm really interested in this outlier result you have around salary. We had a range of salaries that community health workers were paid, ranging from I think $3 to $3,800 a month. And Dickson highlighted this 3,800 and he said, this seems like a massive outlier. It's from Malawi. I want to know which organization's paying this. And so sure enough, we went back and looked through all of the data, but this is where there's so much benefit from working together.
Yeah, that's very true.
I don't understand CHIC also as a research facilitator and donor, kind of, because at least from my experience, there's often projects with a donor, with an agenda, and somebody enamored with a certain way of doing a project, and that's also how data is collected. And are you one of those donors but trying to do it better? Better way of putting it, James?
So we're not a donor per se, so we will have money given to us as an organisation, but our job is to kind of shepherd that and make sure that we're working collaboratively as a team. So SHIC, to be clear, is made up of member organisations. And so as a secretariat, for example, myself, Christina, Madeleine, we will never make an executive decision to say, we're going to push to do this project because this is our agenda. We always present it to the wider member body and make sure that anything we're doing is aligned with member priorities, it's aligned with community health worker priorities, and then importantly, as kind of Madeleine was articulating in the video, it's also aligned with policies that are going to be put in place by governments, because ultimately, I think for anything to be sustainable long-term, you have to have buy-in and partnership with government, be it national government, local government. And so our job really is as shepherds of funding that is granted to us. And then we'll try to do projects that are impactful and meaningful. And we judge that against various criteria that I won't necessarily go into, but I'm happy to have a conversation after this about how we decide which projects to pursue or not.
I think that's pretty amazing, and it does look quite different from a lot of the projects that I've encountered in the US, for example, this coalition-driven approach. But since you mentioned policy and governments, and it was also so important in the video, and you're also pushing for policy change, that's sort of the next step, even though it's the dissemination part, but it's even more. Prossie, can I bring you back in reflecting on how does that work to involve policymakers in your SHIC activities?
Yeah, thank you so much. As like other health professionals, being a CHW can be both mentally and physically challenging. It is therefore crucial that policymakers put structures in place to effectively support pro-CHWs with their vital work, and that time demanding roles and time demanding. It's time for the policymakers to create a space in the room whenever they are discussing about health issues and include pro-CHWs on the table. So far, for long discussions about CHWs have happened without CHWs. It's time for a change. Nothing for CHWs without CHWs. For the first ever CHW Speakers Bureau fosters more equitable global dialogue. It gives us opportunities to speak about issues concerning on local, national, and international stage. We recruit our fellows globally and do the course and learn how to use digital tools, and after they join the Speaker Bureau. The network of CHWs, we engage them in advocacy, ensuring that every time we are talking about the CHWs, we are in the room and ready to participate. So CHWs across the globe are coming together to demand the salaries, ongoing training, support, and supplies needed. The way everyone can access high quality health care. So it's time to shift the spotlight. CHWs must be involved in high-level decision-making. Thank you.
Thank you, Prossie. And I can only encourage everyone to check that out. There's a Speaker Bureau on the SHIC website, and there's so many resources and so much research up there. Can I ask you to wrap up, maybe all of you, out of all things that are now happening and that you are pushing for and that you are advocating for, What are you thinking is the most urgent thing that needs to change? A big question, but what would any of you like to highlight?
Yeah, I think I should start. The first thing is motivation. You know, a health worker, a community health worker should be motivated when he or she is in the community. So how? It's through salary. Yeah, time has gone for one to be working as a volunteer. Now it's time for one to work and get paid. So as much as we are paid, we are motivated and we go in the villages, in the communities to do the best of us. The second thing is about capacity building. This is to be skilled. You know, you cannot go in the community to do vaccination, to do treatment of different illnesses without being trained. So that should be the key thing to be done or to be offered to the community health workers. And also, we need to be supplied. You can't go in the community without resources. We need to have resources. We need to have drugs so that those children who are sick should be treated right away in the communities. And also, supervision is so paramount. You cannot just be working without being supervised. Some people have to come and see what you are doing, whether you are doing the quality work or not. So that's also the other thing that CHWs need to be offered. Yeah, that's what I can say about the key things for what the CHWs should be offered, and also the good environment where all things should be done without fear and with free mind. Yeah, that's what I can say. Thank you.
Thank you, Dickson. Would you like to add?
Okay.
Maybe see what Prossie says first. I think it's really influence my answer.
Okay. Okay, thank you so much. I want to go beyond Dickson, what he has said, and thank you, Dickson. Yeah, the sustainability of CHW programs, like we can be trained like this time there is MPOX, and they train you, they stop there. But we need ongoing training and that better supervision to help guide and coach CHWs so that they can stay up to date with health guidelines and ensure uniformity in standards and compliance. When we talk about salaries, for sure there is nothing but as a starving boss. There is no way how we can go in the community and you who's going to give them hope, you are starving. Your children are in the house, they didn't go to school, and you say that I'm here to teach you, I'm here to give you hope. Even you need hope. So when we say that we need salary, that financial support can help in form of education support to CHW's children or support for incoming generating activities. The skills. When I talk about the skills, we are looking to continue serving our communities. For sure, there is a difference between a pro-CHW and a CHW his or herself. Since I finished the course, I'm serving differently from others because I know how to do research on each and everything. Now there is this MPOX. Me, I've gone beyond because I attend the course. Many times, James is correcting us. Now there is this, you come and we talk about it. What is the community thinking about it? I know how to use digital tools and I go deeper. I serve and make it easier to connect with the professionals, leaders from all aspects. I'm connected. This time I've been with the Ministry of Health. That is where I'm from. Because of this digital tool and the course I got through, I know how to use and connect it to the professionals and leaders from all aspects. When we talk about supply, with both commodities and digital tools, which helps the CHWs to deliver a measure and the services and provide our client with the real-time data and the guidance. this supply with commodities and digital tool, it will help us to do on-time, it will help us to collect on-time data. When the thing happen in the community, immediately I will be there to take care or to report it further to the facility and see how it goes. Thank you.
Thank you. So I gather from that quite a few things that must-haves, like general and consolidated, plus the need to constantly stay involved and constantly be engaging with what's going on also in the policy world, new technologies. That's also a huge thing that I can imagine now in times of digitalization and whatever is a quite big ask as well. James, now, do you think you want to add?
So I think Dickson and Prossie have summed it up really nicely. And Prossie said in her first speech, nothing about community health workers without community health workers. So whenever we're asked the question, which is important, the people to ask are Dickson and Prossie, not necessarily myself, Madeleine, Christina, whoever else is in the room. So I think what I can garner from your perspective, and correct me if this is wrong, but I think community health workers, having spent a lot of time working and living with them, they deliver the vast majority of care in the community, especially at the last mile. So if you were to take malaria as one example, out of all of the things that they deliver, if you think about them delivering in terms of speed, coverage, quality, and cost, we know that community health workers can rapidly diagnose and treat 95% of kids with malaria in under 24 hours. That's kind of gold standard of care. We know that they can do that really accurately. So studies suggest that when you compare the diagnosis given by community health work in the community to lab diagnosis or RDT, it's 95% accurate. We know that they can do that in a really cost-effective manner. So care delivered in the community is 8 times cheaper than care that's delivered at a tertiary health centre, because community health workers can get there quickly. And this is talking about things from a health provider perspective. It's not necessarily thinking about what the costs saved to the individual patient or household are. So for example, opportunity cost times, travel times, etc. So we know that they're delivering huge value, and that's just in malaria. If you think about all of the other things that Dickson was talking about, NCDs, mental health, the list goes on, the value they deliver is enormous. And so if we think about things through this lens of the 4 S's, so salaried, skilled, supplied, and supervised, I think all of them, as Prossie and Dickson have articulated, are really kind of intricately intertwined within each other. But the one for me that stands out is definitely pay, so the salaried element, because you can't expect Dickson and Prossie to go to a one-day supervision course or an upskilling course if they have to leave their jobs where they're getting paid, they have to leave their care responsibilities if they're not getting a salary to do that. You wouldn't ask a doctor to go do that. You wouldn't ask a nurse to do this. You wouldn't ask a midwife to do this. The list goes on. But seemingly we still ask community health workers to do that, and something wrong in that. And so I think underpinning all of this is fair pay, and then everything else follows from that. And then I probably would just add 2 quick other things. We talk about, salary, supervision, skill supply. We also have to think about sustainability of this model. So trying to bake that into national policy to make sure that community health workers like Dickson, like Prossie, are supported by regulatory guidance and legal guidance that supports them, their workers' rights, and also thinking about their safety. So we've been doing some work recently around gender-based violence in community health programs, and we've got some early results from a survey we've run across multiple countries. And we found that 50% of community health workers are exposed to financial violence, over 50% are exposed to physical violence, 22% to sexual violence. So all of these things also come into play. Community health workers are giving so much, but yet a lot has been taken of them as it currently stands. So I think there's a lot that we're trying to deal with, but yeah, I'd say salary is so important, but there's everything else that goes into that as well.
Brilliant. I'm sure there's questions emerging in the attendance, but since you were already touching upon it, I would really love to give you the opportunity to emphasize once more how you see your work situated then in the universal health coverage agenda or in the global health agenda, And we were already hearing so much about non-communicable diseases, malaria, and all you do. And maybe it's also fair to say that doctors and nurses are not so much asked to prove their impact on UHC as community health workers are. So Dickson, what is your take on engaging with those big agendas?
Yeah, thank you so much. Yeah, it's very true that if we talk of universal health coverage, it starts with primary health care. So this starts in the communities by the community health workers. So as for me and my colleagues, Prossie and all others, we are geared to do the best work in the communities if we are supported. The support that we need is has already been said. We need to be salaried, we need to be skilled, supervised, and also we need to be supplied. So these are the key elements that will help us to do the best work that will benefit our communities. You know, all these things that we are discussing here, at the end of the day, we need to give the best services to the communities. So this can only be done if we are being given the best of the services for us to deliver. So that's what I can say about the health coverage, the coverage related to primary health care in the communities. Thank you.
Yeah, thank you, Dickson. Prossie.
Yeah, thank you so much, Dickson. So CHWs, we deliver a wide range of services tailored to the needs of their communities in both low and high income countries as CHWs, we bridge the gap between healthcare systems and to underserved communities. We extend health services to populations that are traditionally difficult to reach, providing care in both rural and urban rural resource settings. This decentralization of healthcare delivery is crucial for expanding access to primary care, which is the foundation of universal health coverage. No matter where they are, CHWs build the trust within community. We share important healthy information, screen for common health issues, and gather data. That helps improve healthy decision making. Let's take a look in the pandemic. We worked tirelessly, making sure that the information goes faster than the virus. Everyone witnessed that. Every country with active CHWs, they didn't get a lot bothered with the pandemic, even this monkeypox, even the Ebola, which we had recently in Uganda. Still, we work as role model by taking the vaccine. There is time of bringing vaccine like for COVID-19, the Mambaga, the Ebola, and the monkeypox. But the community can fear to take the vaccine. They can sit there and wait for the community health worker to discuss about how effective is the vaccine. So we work as a role model. You have asked how can that consider with the universal health coverage. So if we are to win, if the world is to win the universal health coverage, they needed to support pro-CHW policies and change guidelines and increase funding for pro-CHWs because we are already trusted in the community. You witness each and everything starts and ends in the community. Last but not least, pro-CHW is the way to go, is the way to win universal health coverage globally. Thank you.
It is so amazing to hear what all is possible, and through you and others already happening. Before we open up, James, would you like to add on?
I don't think I can follow up.
You have to compete for some.
Yeah, be disappointing. No, I won't get any applause, trust me. So yeah, everything Prossie and Dickson said there is on the money. I couldn't really add much to it, to be honest. I can add a couple of thoughts, but really what they've said is what I would suggest. So yeah, I think if we go back to the video and Richard Kiboga from Uganda Ministry of Health was speaking, and he made this point that we have to think about health more in a preventative manner rather than being reactive. And I think that's where community hold huge value. I think, as Dickson said, thinking about this as a tailored support system to countries rather than a one-size-fits-all model is something also to think about. So trying to blend in where a burdens of disease in the country, is it, you know, a greater burden of disease with some non-communicable diseases, is it emerging infectious diseases, for example, and that's where something like the WHO curriculum guide would be really helpful. And then I think, yeah, as Prossie's articulated, trying to not just view community health workers as workers who are working in, say, sub-Saharan Africa, but community health workers have a role in providing universal healthcare globally. So be that in Westminster, where there are pilot projects being run by groups at Imperial, be it in Mexico, be it in the US, be it in Malawi, Uganda. So I think community health workers do have an important role to play everywhere. And so that's what I say.
Round of applause. So many things following up from that, but we should open it up and ask anybody wants to raise a question or make a comment on the discussion of the panel. And I see a loud yes here. Shall I move over to?
Okay, so I'm sure we have a lot of questions coming from the floor and from online. We've had a few questions already through there as well. So yes, opening up, please raise your hand if you have a question. Yes, over here.
Hi there. Thank you so much for that. I really enjoyed the last hour. It's brought a lot of things to life. It's raised a lot of questions for me. Sorry, my name is Cathy Dodworth. I'm a researcher at the University of Edinburgh, and I'm quite recently come to conduct research with community health volunteers in Kenya, but I have a long-standing interest in voluntary labour and the history of that in East Africa specifically. I had a question for each of you. Prossie, you mentioned in the challenges around information overload, and I wondered whether you could bring that to life a little bit for us, understand what that looks like on a day-to-day basis. I'm also interested, has that got worse or has that got better of late? Does digitization help streamline? Is it an issue with multiple organisations, or things cohered a bit better in Uganda under Ministry of Health and then local government? So I was really interested to hear more about that. Dickson, I was interested when you were talking about salary and also community health workers becoming formally government workers. I think the idea of voluntary labour has been used by international bodies and also domestic governments for a long time to sort of offset or to circumvent calls for professionalisation. So paying community health workers somehow demeans the work, or you're going to change the incentive structure and get the wrong people doing it. And I think all of that has been debunked and moved on from those kind of what were quite insidious claims, I think, to stop community health workers getting paid. I guess I'm quite interested in the Malawi case. because I expected going into my research that all community health volunteers in Kenya said they would want to be salaried and want to be on government books. But then actually unpacking it in some of our interviews, some of the volunteers would use their voluntary status to diffuse tensions with their own communities, particularly in a very sort of low resource, challenging environments whereby it could undermine trust, where a community health worker becomes a government worker. And it just seems like in the Malawi case, you've overcome that. And I'm just interested to hear the salaried versus the unsalaried cadre. Did it make any difference in community relations, or it was all just fine, in which case I think lots of other settings can learn from the Malawian case. And James, I just had a question around co-authorship. Actually, it's not a great question, sorry, it's more like a comment. But it made me think that were there.
Sorry, there's already a lot that you've said. I was wondering if we could just get the answers to the first two questions.
My apologies.
Yeah, because they're all the really good questions. Okay. I'm sure we'd like to hear the answers.
My bad.
Okay, Dickson, would you like to maybe, I think the question for you was around information overload? Prossie, sorry. Yes. Prossie, can you hear the question? It was about how you're managing information overload.
What does that look like? Information overload, has it got worse? Has it got better?
Were you able to hear the question?
Hello?
Hi, we can hear you.
Could you please help me and come again the question?
So, Prossie, the question was about information overload. So really asking how, whether you're able to manage it, how you're managing it, has it got better, has it got worse? Does digitization help with information overload, or does it actually exacerbate information overload? Those were the group of questions for you.
Okay, thank you so much. And I'm sorry I didn't hear the name who asked that how of digital information, isn't it? Yeah. How I'm managing it, as I have explained at the beginning, that I get the course to know how to use the digital tools as a Prossie. So there is still this gap of other CHWs who don't know how to use those digital tools to collect data in the community or to join the virtual call like I'm doing. So how we are handling that, we are getting mentorship and supervision from Community Health Impact Coalition. When they introduce the course to the CHWs, and we get knowledge to use how we can use these digital tools and collect data in the community and join the cause. There is another method of desk. That desk is helping a lot of CHWs in my country, more those with digital tools. Unfortunately, 50% of CHWs here, they don't own smartphones. So those who don't own, we normally go there and support them. And it's like, as I've said, 50% don't own and 50% they have. We can use one phone and take the report from a CHW. If they don't own smartphone, they have small phones just to make call and get help from others. I don't know whether I'm clear. Thank you.
Thank you. And then we had the question for Dickson was to do with the
fully salaried community health workers. Did it cause any issues with communities in that cadre? Did it cause any issues with the unsalaried cadre? Are there lessons to be learned from the Malawian context?
Yeah, so the question of, I think it really relates to local community relations and power relations. There were a couple of questions about that as well on the chat. So asking, for example, the problems that we know about with health workers, with salaried health workers, problems to do with absenteeism, problems so the question there was also what's being done, or is there a potential challenge ahead that with your professionalising and having salaries that you then start to maybe encounter the same kind of problems that we're already facing with salaried health workers in some context? So I think it's a group of questions around what are the potential downsides or challenges of professionalising without getting into that rabbit hole of trying to counteract the reform, so supporting the reform, but saying what are the challenges of salaries and professionalisation?
Okay, thank you. I think I'm happy that the question has been cleared. At least I know get it right. Yeah. The first thing that we should know is that these salaried CHWs are recruited right away from the communities. So if a community health worker has been recruited and has been put on salary, it means he or she has got a trust from the communities that she is serving or he is serving. So the issues of maybe not doing the right job in the community for Malawi is not there, because as long as you are employed, you follow what government rules and regulations say. And also there are a lot of intensive supervisions to your daily activities. You have to submit the reports, you have to submit work plans, and also you have to follow whatever is needed for your work to go on well. So I think on the issue of maybe doing the opposite in terms of being salaried, is not an issue in Malawi. Again, if we are working together with unsalaried and salaried, these people who are not unsalaried, they wish to be salaried again. So it's like if you see somebody is being salaried, you work hard so that next time it will be you being put on the payroll. So yeah, it's an issue that we should do. Sometimes people may say these community health workers just want money. All the time the mission of money. But you look now, most of the CHWs are volunteers, they are working. If you talk of treating people, they are doing the work, but they are not being paid. So why should we talk of money today? This thing is there for us for our own upkeep. We have children now who have to go to school. We have to eat. We have to dress. So all these things that we are advocating for is for us to live, to survive. Everyone is here to survive. So yeah, we should talk of these salaries as provision, skills, supplies as the normals of one's life. So it's not a strange thing, it's a normal thing for a community. Thank you.
Thank you. I know you had another question to James. Yeah, we could. Yeah, maybe you could afterwards have a conversation. Sorry, James. I think I'd like to open up to see if anybody else has a question. We'll quite a few. Yes, I think. Yes. Would you like to ask a question?
But before I ask, I think Prossie raised her hand.
Yeah.
Oh, thank you. Prossie, did you want to add something?
Yeah.
Please go ahead.
Yeah, thank you so much. Just I wanted to add input about Dickson. Dickson, thank you so much for sharing. About for salary or unsalaried CHWs. For sure, we can say that this community we are serving. Let us first ask a question: who are community health workers? We are local person in their community. We are non-politician. We are selected by local leaders to serve our communities. So when it comes for salary, as the moment we are serving people whom are working with, our relatives, the people who are staying with, I think we will be sharing. As we have been sharing the information, still we have to do something for the community. Last time was the meeting with the chairman, LOC1, that is local leader. I told him that, you see, as the moment we have this small garden, if we get something, we can dig like greens or chicken, and we get eggs. We can sell on low price so that we can avoid these malnutrition children in the community, these under 5. And we can sell these green to pregnant mothers so that they can give birth to a healthy children. So when it comes about that, as we are sharing the information with the community, we will be sharing each and everything as we have been doing. I think that it's not like to fear anything for the community, because we are serving the people who really need us to help them, and we are willing. As we have been working as volunteers, even if we get salary, you just assume that we will add more because we will be motivated for our work. Thank you.
Thank you. Thank you, Prossie. So we have another question from the floor.
All right. Yeah, so good afternoon. And first, I'd like to congratulate and thank you all for joining us. I think it's very hopeful to see that there have been successes and movements in other areas of the world. And now my question is coming from a more practical perspective in terms of our previous work into lobbying for it. So we're part of, in my previous work, we were part of within government, like internal reforms in order to focus more on the primary care perspective of health. And one of those is really arguing for the need for community health workers. And as you mentioned, there are so many aspects of it, including professionalization through salaries, capacity building, support and supervision, etc. And as much as we want this, there's always a large cost that's attached to that, which may make it difficult for it to actually be absorbed in a higher level decision making. So I guess I'm curious, like, do you think in your work in CHIC, like what's actually like a viable strategy, something that can be replicable in terms of how you will actually argue for these very somewhat difficult work perhaps that policymakers and implementers will have to do, like a viable strategy that possibly could be replicable in other countries so that we can actually achieve professionalization for community health workers.
And can you, I might have missed it, other people might have as well, tell us again what Ministry of Health you've been working in? I know the other
Philippines.
From the Philippines, exactly. Thank you. Yes, so question from one of our students who has been working in the Ministry of Health in the Philippines. Any particular person you're directing your question to?
I think anyone can answer the question.
Okay, so Prossie or Dickson, one of you, would you like to go first?
Okay, maybe I should get it to the last point of your question because I missed it. So I may answer it maybe differently the way you wish I could take it. I don't know if Prossie, if you have understood it. So
I have an idea.
So I think, was it to do with how do you make the case for the increase in budget, even though the idea here is that it's not supposed to be a huge increase in budget from the Ministry of Health. So you're not asking for salaries that are, up there with the bankers and whoever else. You're asking for reasonable salaries, but it still implies a budget and an increase in the Ministry of Health budget. How do you make that case? Is that what you're asking? Yes.
Okay. Thank you so much.
Yeah. Okay.
Prossie, are you starting or should I start?
It's okay. Yeah, thank you so much for that question. As CHWs, when we are advocating, we say fair salary because our work, for sure, no one can pay for our work. As was it yesterday, Dr. Madeleine posted the biggest sponsor 2023. Everyone was thinking about USA government, what, no, it's the community health workers because we dedicate our life to serve the community, even in hard circumstances, we are ready to take the responsibility. When we are advocating, we say fair pay, fair salary, at least something. We can't say that we want a huge money. No. We want small, not as much as people think. Even today, I've been with a meeting with the Ministry of Health that if it comes for paying for CHWs, it will be like a big budget. That's why they are recruiting queues at the parish level to pay them. It's still to be a little money, not a lot of money. I don't know whether I'm clear.
Yeah, thank you so much. I think for me, the issue is prioritization by the government. If we go through in different ministries, but departments, ministries, you find that some of the budgets that are allocated there, I can call them the useless. So it's an issue of what's the priority for that government. I don't think they can absorb all the community health workers at one go. Maybe that's impossible, but they can do it little by little. At least each year they employ 10,000, 15,000. By the end of 5 years, you see that a lot of CHWs are salaried. And also, as I've already said, some of the priorities in governments, they are not for the communities. Some of them, they are just benefiting the political leaders. So if there is a political will, this is very possible, and it can wait. I don't see any obstacle with recruiting CHWs. Thank you.
I think just as well to add to the point, one of the things that we try to do is try to present actionable evidence to policymakers. And so something we've done recently is done a large-scale suite of scoping reviews looking at both cost-effectiveness and affordability of community health worker programs. So we looked at all of the literature over the past 10 years that have costed this. We split it down into horizontal programs, NCD programs, infectious disease, etc. So just taking the example from the horizontal program analysis, we looked at 42 scenarios across several different low and middle-income countries, and we essentially found that of the evidence presented, community health workers were found to be highly cost-effective, and albeit in limited scenarios, also highly affordable, depending on different thresholds that we used. So I think from that argument, we're able to, as a coalition, coalesce and bring together lots of evidence and try to distill it down into a language that ministries of health, but probably most importantly, ministries of finance understand. I think the other argument to be made is to not look at this just purely through a fiscal lens, but also to see it from the language that the ministries of finance speak. So trying to say to the ministries of finance, okay, this is going to be a budget line, and sure, it might be expensive, but think about the jobs that can be created and the other societal benefits that can come from this. So I think one of the jobs at Chic is to try and bring together lots of interdisciplinary groups and look at this through a lens that isn't just purely about health outcomes, albeit those are important, but think about the other benefits to the wider economy that can come from paying community health workers and having them as part of a government-supported workforce. So I completely appreciate your point, and it's a point that is raised. It was an excellent question, but it's also one of the aspects that we do in line with advocacy as well. So giving them the evidence, but then acting on the evidence. And I think one of the other things that we would do is try and bring together things like exemplars. So find the countries where this has been successful and use those as flagships for other countries to hopefully then to.
Thank you. We have so many questions online and from the floor, and we are starting to run out of time. So I feel like we could go on and on and on. But yes, I think let's try and have one more question and then we'll see how we're going. I think you've had your hand up several times, so I'm going to ask you to go ahead.
Yeah, thank you so much for the talk. Really appreciate your words. Okay, yes. So I think coming to one of your last points, James, is about interdisciplinary groups. So I wanted to know what is the role of other organizations, because I mean, community health workers are providing allied health services. We have the medical doctors, we have the nurses. What is the sense? Because I keep, as I say here, I keep wondering, it's clear the impact that the CHWs have, but there's still this persistence in the lack of recognition and lack of support. So I'm just curious, are there some hidden things that we don't know about? What is the sense you're getting amongst other, healthcare professionals regarding the role and the support that they have for CHWs?
What's your perspective, Dickson, in terms of Would it be when the community health workers are working with other health professionals such as doctors and nurses? What's the interaction?
Yes, I think getting support from them when you're advocating, with government, are they coming alongside to advocate, or is there a position, from there? Because I keep wondering what is holding us back from moving forward?
That's a great question.
Yeah, at some point that works, but when one is getting salary, maybe you cannot feel the pain of someone who's not getting salary. So it's not all the time that we are together. Sometimes we are alone, we are fighting for this battle alone. So yeah, it depends, it depends. So the answer, but it depends. But most of the times we are alone advocating for the pay, so it's just because it is us who are feeling the pain. Yeah, that's what I say.
I think something else that's important as well is to see health systems as health systems. So, for example, if you think about the UK context, when a patient goes into the accident emergency department, they're greeted at the front door by an allied health professional. A nurse will see them, take their observations, they will go through, they'll see a junior doctor, then they might go and see a consultant, for example. So I think it's the same with community health workers. Community health workers are involved a lot in task shifting and task sharing. And so I think other health professionals do need to recognise the immense value that they're bringing. Something that we're trying to do at Chic is to try and support the community health workers in forming national unions. And that will be one process of helping them advocate for themselves better. I think something we can learn from is national or international unions that have been set up by, say, doctors, midwives, nurses. And in that process, trying to bring some of those expert leaders on board to have a more surround sound system. But it is really important, like you mentioned, so that the community health workers like Dickson and Prossie aren't banging on the door alone, but they're being supported by their colleagues. But that comes with a lot of complex areas, especially if they're on government payrolls, complexities with unionisation. So it's a really complex question that I probably could have a long talk with you about. And also there's lots of work being done about this, especially at Harvard Law School. There's a whole centre that's been set up around healthcare unionisation, complexities around that, and learning from interdisciplinary fields. So I'll talk to you afterwards about it, but it was a great question.
Thank you so much. I think we are now running out of time. We do still want to have enough time to ask Madeleine Ballard to come and talk to us just for the last few minutes about where Chic is going next, looking to the future, and any reflections that you may have on our session. But before I do that, I just wanted to thank the panelists for such a wonderful and engaging conversation. So thank you very much. And Madeleine, if I can hand over to you.
Thank you guys. That was the main show. This is just the wrap up. We were reflecting last night. I shared a quote from the journalist Barbara Ehrenreich, who you may know, and if you don't, I encourage you to go read her. But she said that if someone works for less pay, then she can live on. If she goes hungry so that you and I can eat more cheaply or conveniently, then what she's done is she's made a great sacrifice for you, right? She's given you a gift of some part of her health, her abilities, or her life. And I think together, as a team, we've encapsulated this panel, I think, quite well, that to be a community health worker, you're an anonymous donor. You're really just a nameless benefactor to everybody else. And we are working for the day in which community health workers are no longer the world's leading philanthropists. It's not the names on the buildings, it's the names on this panel and in this room. And our vision is really health for all, right? And that has to include the people who provide it. And I think we've forged a pretty amazing approach together that can lead to that policy change. And it starts with the research, because that's what global guidelines like the World Health Organization, Africa CDC are based on. These guidelines are the blueprints that many countries use to design their health systems. It continues with advocacy, particularly to increase the amount of funding that's going to community health, both nationally, but also internationally, right? There's so much money being poured into vertical disease programs, and those programs have saved so many lives. But we also know that they're not going to get us to where we need to go, which is universal health coverage. So how do we begin that integration? And then finally, it's really activating in-country networks. Health is not just technical, it's also political. So there has to be that demand. Ministers of health need to be thinking not just, oh, what do doctors think, what do nurses think, but also what do community health workers think? And I think that's, as you heard from James and Dickson and Prossie, a little bit of what this group has achieved thus far. And I really like the example that Prossie gave on the panel. You know, I think at this point, the evidence is very clear. When we treat community health workers like professionals, fewer people get sick, fewer people die. And there's actually a really compelling paper we worked on together during COVID. You know, a time when disruptions to essential health services caused really huge additions to the mortality rate from the disease itself. But actually not everywhere. Where there were professional community health workers, so 27 districts across 4 African countries, we saw that speed and coverage of care was maintained throughout the entire pandemic period for 5 million people. So I think there's a lot. You know, James mentioned the cost effectiveness review that we did. I think that underestimates actually the savings when you think about these, unfortunately, increasing number of catastrophic events that are headed our way with climate change. Of having that trusted interlocutor already in place. Pre-existing partnerships really pack a punch, right? We can coordinate, we can share information, we can do a response at a level that's really unmatched by anything that we try to cobble together in the moment. So I guess our question for you all is, how are you gonna get involved? And we have kind of 3 invitations for you today. The first is to head to joinchic.org. If you liked hearing from Dickson and Prossie and James, you can actually just sign up to receive their voices in your inbox twice a month. Once the latest research on community health workers, and then twice sort of latest updates from the movement. And that's just kind of a nice way to keep in touch and stay connected to these issues. If you want to take it a step further, if you head to joinchic.org, and you actually click on the button that says Join Us, the top right-hand corner, or if you're on mobile, it's on the menu. You can actually sign up as an ally. So James mentioned that the coalition is thousands of community health workers and member organizations around the world that devote considerable sweat equity to doing research together and advocacy and organizing. But we also have a 30-minute kind of open call every month. That's an optional briefing on just kind of what the different groups are working on. And we invite folks to join in. And it could be a simple invitation, 5 minutes, like, hey, share this on social media. It could be a much longer invitation. Do you want to be part of this research study for the next 3 months? You know, get in touch. So that's a way, if you're looking to deepen your involvement, that you could. We'd also encourage you, a third thing that you might do is actually, if you're still on X, I don't know if we are still on X these days, but if you are, if you go to join_chic, you'll find a great list that we've curated of community health worker accounts. And if you follow the list, you just follow them all. And so we'd say amplifying community health worker voices, and basically what Prossie said, nothing about CHWs without CHWs. So retweet, share, the community health workers are constantly posting about policy processes happening in their countries, and also about, you know, opportunities to support their work and also to be in solidarity with them. So we'd say definitely do that as well. And I think I would just conclude by saying, you know, our movement is growing, that making professional community health workers the norm, it's not just an ethical imperative, it's a no regrets investment, as we heard, because when you support community health workers, you're not just strengthening individuals, you're strengthening all of our communities. whether that is Churchill Gardens just down the street in Westminster, or it's, Mukono, Uganda, as you saw in the video, or it's Malawi, as Dickson shared. We're really fundamentally all in this together. It's not a second best option. It's actually the standard of care for preventative care, promotive, chronic, and so many things that are facing us in cities as they are in rural areas. So we'd love for you to get involved. And I think, at this point, we're still young. We're only about 5 or 6 years old, but we've definitely put community health workers, professional community health workers, firmly in the spotlight. And now it's up to all of us together to make that just the unquestioned standard. So we really would invite you to join us, and we'll be around for a few minutes afterwards to chat more. But I'll hand it back to Philippa.
Thank you so much, Madeleine, for wrapping up so beautifully. I can't actually thank you enough, because we just came from a lecture where I said a lot of the things that you just said. And as we know, when our students hear these things from different people with different voices, with different examples, then the learning gets deeper and more engaged. So thank you so much for coming to the LSE and sharing your work with our students and helping them with their learning and their understanding of these complex issues with how to strengthen health systems and work towards universal health coverage in many countries in the global south, but also countries that are still struggling in the global north with these issues as well. And thank you everybody for coming along. Thank you to the great participation online, and sorry that we didn't get to all of the questions. Just a shout out for our next event. So the events just keep on coming. And again, it is very much connected to what we've been talking about, because this evening, Leoba Hirsch is coming to publicise the launch of her much anticipated book, Anti-Blackness and Global Health, a response to Ebola in the colonial wake. And so talking about how pandemics tend to derail health systems if you don't have strong health systems founded on properly paid health workers, then that's, I'm sure, part of the story that will be discussed at this event, which is happening here at the LSE at 6:30. So please do take a look online for the details of that event and join us there this evening, hosted by the Department of International Development and the Global Health Initiative. So with that, I will wrap up. It's time to go, but please do come and say hello.
I just also want to recognize it was Claire Wyndham that actually brought us to the department. So thank you, Philippa, and thank you, Tina, for moderating, but also thank you, Claire, for kind of making all this possible.
Great. Thank you.